So, good evening to all of you. Thank you, Jabez sir, for the wonderful introduction. So, we'll be discussing something regarding the finerenone molecule. We'll be discussing that in detail. So, without much delay, we'll be directly moving towards the topic. Finerenone, a disease-modifying therapy for heart as well as kidney protection. So, if you see the association of type 2 diabetes mellitus as well as cardiovascular disease as well as kidney disease, we know that CVD burden in type 2 diabetes mellitus is almost 2 to 3 times. And if you see the higher rates of hospitalization and reduced survival which occurs in patients who are having type 2 diabetes mellitus along with CVD. And if you see the CKD burden in type 2 diabetes mellitus, all depends upon how you screen the patients. Around 37% of the patients are having albuminuria in type 2 diabetes mellitus in India, and there is 10 times higher risk of kidney disease or kidney failure as well. So there is a strong interlink between type 2 diabetes mellitus as well as CKD and CVD. So this is again, you can see here the number of years lost due to individual disease in men as well as women. Early CKD is almost 6.7 years and 5.7 years respectively. Diabetes, which is main villain, is like 11.7 as well as 10.2 years. And if you are having early CKD in type 2 diabetes mellitus, the number of years lost is like almost 17 years in women as well as almost 15 years in men. So a patient who is having early CKD in type 2 diabetes mellitus should be screened and should be diagnosed, and we should prevent further progression of chronic kidney disease. Now the question comes, why is the assessment of albuminuria considered crucial in patient type 2 diabetes mellitus? Because when we work up a case of type 2 diabetes mellitus, you can see here this patient who is having type 2 diabetes mellitus. If you see the EGFR for this patient, it is like 62 ml per minute. And you know the grid. This is a grid which is showing the relative or the risk of progression to a chronic kidney disease in a patient with diabetes mellitus or any disease. So you can see here, we are having EGFR criteria in one axis and the albuminuria criteria in the other axis. So if you consider only the EGFR, this patient is having EGFR between 60 to 89, that is G2. So his risk of progression to kidney disease is very less. He's in the green zone. But if you measure the urine albumin creatinine ratio, it is like 350 milligram per gram for this patient. So with a G2 category, if the 350 milligram per gram, it is A3 albuminuria category. So this patient moves towards the right. That means the risk of progression to CKD is almost, you can see here, almost 3 columns on the right side. So that is it. So albuminuria along with EGFR is a strong predictor for the future CKD. So the guideline recommends using both EGFR as well as urine albumin creatinine ratio to properly identify, stage and monitor CKD patients in type 2 diabetes mellitus. And EGFR alone may miss the early stages of CKD. Some of the patients may be having albuminuric CKD with a normal EGFR as well. That is important. Now, the association between albuminuria and kidney fibrosis, we know the pathophysiology. The EGFR, we know that in the early stages, the EGFR will be slightly increasing. Then that is followed by a dip in the EGFR. And you can see the albuminuria, the second graph, it is going up directly from different, So from to the different stages of CKD as well as the duration of diabetes progresses, and you can see the fibrosis, kidney fibrosis, which is parallel to the albuminuria category. So albuminuria indicates a kidney fibrosis, which is going along with the measurement. Now, you can see the importance of urine albumin creatinine ratio. You can see here, if you see the urine albumin creatinine ratio more than 30, there is a significant increase in the all-cause mortality as well as cardiovascular mortality. So we can say that a urine albumin creatinine ratio not only important to monitor the kidney disease, but it is also a predictor of all-cause mortality as well as cardiovascular mortality. And we should try to reduce the urine albumin creatinine ratio in patients who are having type 2 diabetes mellitus. So you can see the guidelines. So at least annually, you should measure the EGFR as well as urine albumin creatinine ratio. So how will you do that? The single void spot urine sample, it is the most convenient measure to albuminuria because a 24-hour urine sample may not be possible in all patients. And you can collect a spot sample. So exercise within 24 hours, infection, fever, heart failure, marked hyperglycemia, menstruation, and marked hypertension, all these can affect the EGFR. It may not be directly correlating with the underlying kidney damage. So you should be careful while interpreting this urine albumin creatinine ratio, especially if the patient is having SGLT2 inhibitor. Patient may be associated with UTA, which can increase albuminuria. And even though the patient is having albuminuria, a reduction of at least 30% of the albuminuria, it is helpful in preventing the CKD progression. So even if you cannot normalize the albuminuria, at least 30% reduction from baseline is an important parameter. So now all the question is, all are all the drivers of CKD and CVD progression is being addressed. It is, you can see the drivers of CKD and CVD in type 2 diabetes mellitus along the progression of these diseases. You can see there are three parameters. One is the inflammation and fibrosis, other one is the hemodynamic parameters, and the third one is the metabolic parameter. Metabolic parameters for glycemic control, and hemodynamic is elevated BP as well as increase the intraglomerular pressure. What does it do? It increases the tubulointerstitial damage and inflammation, glomerulosclerosis, mesangial expansion, glomerular hypertrophy, all can lead to kidney failure, as well as, on the other hand, it can produce myocardial fibrosis, atherosclerosis, and vascular stiffness and calcification and ventricular hypertrophy, leading to heart failure. So this is a picture that you all should keep in mind. So if you see that mineralocorticoid overactivation is the most important thing which is contributing towards the inflammation as well as fibrosis. So you can see here mineralocorticoid activation. You can see here the aldosterone as well as cortisol. When there is a stress as well as when there is an increase in the renin-angiotensin activation, the aldosterone and cortisol can act on the mineralocorticoid receptor along with oxidative stress. All these can produce inflammation and fibrosis. So one of the way to prevent this one is the blocking the mineralocorticoid receptor. So finerenone is primarily a molecule which blocks the mineralocorticoid overactivation, slowing the kidney as well as cardiovascular disease progression. So finerenone, you can see it blocks the recruitment binding of transcriptional cofactors when it is binding the mineralocorticoid receptor. So what it is doing, it prevents the inflammation as well as subsequent fibrosis. So the hemodynamic parameters, inflammation, fibrosis, and all these parameters are getting improved, and there is a decrease in the progression of CKD as well as heart failure. So this is the difference between a steroidal as well as a non-steroidal mineralocorticoid receptor antagonist. We are having three molecules: spironolactone, eplerenone, both are aldosterone antagonist. These are both are steroidal, and finerenone is the molecule which is non-steroidal, and it's a bulky molecule. You can see here the half-life. Spironolactone is the highest half-life, like 20 hours, and eplerenone is 4 to 6 hours, and the finerenone is 2 to 3 hours. And finerenone is having high selectivity for the mineralocorticoid receptor. And if you see, the breast-related side effect is much less for finerenone, or almost nil for finerenone. So if you see the short half-life and there is no active metabolites for finerenone, the chances of hyperkalemia is also on the lower side. So these are some of the differences in structure, in selectivity of its action, breast-related side effect, as well as the side effect of hyperkalemia. So this is the holistic treatment approach for CKD. You can see here we are having RAS blockers. It decreases the efferent arterial tone, so hyperfiltration is reduced. Endothelial dysfunction, cardiac remodeling is also reduced. That's one way of doing the thing. The second way is by SGLT2 inhibitor. We know that it increases the afferent arterial tone and tubular-glomerular feedback, and anti-inflammatory and antifibrotic effects. So it again decreases the hyperfiltration, proteinuria, and oxidative stress. And the third one is the finerenone that we have discussed. It reduces the inflammation and fibrosis basically, and reduce albuminuria. And the fourth important molecule now coming up is the GLP-1 receptor agonist. It primarily controls the metabolic parameters, and like weight reduction as well as dyslipidemia and oxidative stress. And further, the role of GLP-1 receptor agonist on kidney protection is being studied in different trials as well. So even if you see the RAS inhibitor use as well as SGLT2 inhibitor use, there is a residual risk of kidney disease progression. We know that as compared to placebo, a RAS inhibitor as well as an SGLT2 inhibitor is better in preventing the chronic kidney disease progression. But still there is a residual risk. How it can be addressed is a question. So now comes what evidences support finerenone's cardiorenal benefit. So if you can see the cardiovascular, the renal outcome trials or CKD trials with finerenone, these are called the Fidelio DKD as well as Figaro DKD trials, and Fidelity is the pooled analysis of these two trials. So you can see here the kidney outcome trials for CKD with type 2 diabetes mellitus. You can see here the AC inhibitor trials are renal as well as irbesartan trials. Then Credence trial, DAPA-CKD and DEMPA-kidney trials were for SGLT2 inhibitor, and the Finerenone, the trials are Fidelio-DKD as well as Figaro-DKD. You can see the N, the number of patients involved in each study. The Fidelio-DKD as well as and Fidelio-DKD and Figaro-DKD almost includes almost 13,000 patients, which is much bigger as compared to the other studies as well. So it is a good analysis of what is the effect of Finerenone in patients with type 2 diabetes mellitus as well as CKD. So you can see here the Fidelity, which is a pooled analysis of both these trials. And if you see that these study included patients who are having CKD stage 1 to stage 4. You can see here the patients were randomized to get Finerenone versus placebo. And you can see here the number of patients as well as different category. So you can see the A1 category 1.7, A2 it was 31%, and A3 category 66%. And you can see here the EGFR also 40% of the patients had a normal EGFR which is more than 60%. So 40% of the patients were having albuminuric CKD and with a normal EGFR. And you can see here the analysis. I'm not going to the each and every parameter, but the baseline urine albumin creatinine ratio was like 515, EGFR was 57, and the potassium was 4.35. And you can see the outcomes of this pooled analysis. Composite cardiovascular endpoint, time to CV death, non-fatal MI, non-fatal stroke or hospitalization for heart failure, 14% reduction as compared to placebo. Hospitalization for heart failure, again 22% reduction. Composite kidney endpoint, that means time to kidney failure, sustained more than 57% EGFR decline, or kidney related death, it is reduced by 23%, and dialysis incidence or progression to dialysis also reduced by 20%. So it's a very good molecule in preventing the cardiovascular as well as kidney outcome parameters in patients who are having diabetes mellitus with CKD. You can see the clear graph which shows a decrease in the urine albumin creatinine ratio reduction. With 4 months of treatment, you can see the 36% reduction with Finerenone as compared to the placebo. And as long as the patients were followed up for up to 48 months, the difference in the urine albumin creatinine ratio reduction was continued. And you can see the side effects. Almost the side effects profile was similar in both the groups. What is the most important thing? The difference in this two groups is any hyperkalemia was significantly higher for patients who are using Finerenone. Hyperkalemia leading to permanent discontinuation is again 1.7% versus 0.6. In clinical practice also, what we face as a challenge is hyperkalemia. So what are the predictors of hyperkalemia while using Finerenone? High baseline potassium, lower EGFR, higher urine albumin creatinine ratio, and concomitant beta blocker use. So in these patients, you should be careful. And the maximum difference in the potassium between the two arms in this study was 0.19 millimole per liter. But in clinical practice also, you should be keeping in mind the chances of hyperkalemia and the importance to monitor the potassium in these patients. Now coming to the last part of my discussion, the real world evidence of fidelity outcomes. So the Fountain trial is the real world evidence of patients who were started on Finerenone, what is happening in the real world evidence. The other one was the randomized control trial. So you can see here, these patients include around, this study included around 16,000 patients. And you can see here, the urine albumin creatinine ratio at the baseline was like 203. The EGFR was 50 and medium serum potassium was 4.5. And all these patients were new users of Finerenone. You can see here what is happening to the urine albumin creatinine ratio. It's the most important thing. At 4 months, there is 33% reduction. And by 12 months, there is 38% reduction. And you can see here, among these 16,000 patients who used Finerenone, the chances of hyperkalemia was 1.32%. And hyperkalemia associated hospitalization was 0.04%. So this is an important thing that also should be kept in mind. So the key points that I have discussed is albuminuria is a predictive marker of CV as well as kidney events, and urine albumin creatinine ratio is recognized by major guidelines as a treatment target to reduce the CKD progression. Early stage CKD management is often missed. However, if managed appropriately, its progression can be slowed or halted. Inflammation and fibrosis with melanocorticoid overactivation contributes to CKD progression, and it is usually unaddressed. Fidelity results indicate that Finerenone is an effective treatment option for CV as well as kidney protection in patients with the CKD stage 1 to 4 and type 2 diabetes mellitus. And we are having the real world evidence like found in data on finerenone, which shows lesser incidence of hyperkalemia among the 15,000 patients. So I hope you have understood some of the important points regarding the finerenone use, when to use, what are things to be monitored, and what is the efficacy. I stop my presentation over here. I'm handing over this to Dr. Suraj for the further discussion.